to switch now to another talk and to hear more about I think, what I believe a very exciting area and very new area in the field is the role of the gut microbiome in regulating and modulating response to cancer immunotherapy. So Jason has focused on the mechanism that play a role within the tumor and therapy targeting this mechanism that impede immune response within the tumor microenvironment. But outside the tumor, there is now mounting evidence that the gut microbiome also play a role. And Dr. Davar, who is leading this area within the program, is going to talk about that.
So good morning, and thank you very much for the invitation to speak. And thank you, Hassan, for the very kind introduction. What I'm about to talk about is the role of the gut microbiome in the context of cancer, specifically cancer immunotherapy. This is a aggregation of a lot of recent and soon to be published work that is really heavy lifting on the part of many people. So I want to make sure that I acknowledge that up front. These are my disclosures. So why is this such a big deal? Well, as it turns out, and many of my colleagues have already talked about this, but we have spent a lot of time in cancer immunotherapy, trying to figure out how to get drugs to work a little better and how to understand what causes immunotherapy not to work. And those efforts have primarily focused along features of the cancer and the cancer's microenvironment, what is known as the tumor genome, the epigenome, as well as the cells that surround the cancer, the tumor microenvironment. Increasingly, we realize that there are certain elements of the host, that is the host's immune system, the context of the immune system. Jason mentioned cells such as the dendritic cells that are present, that need to be present, in the absence of which do not appear to help and may possibly impede the efficacy of immunotherapy. However, it is only recently that we are realizing that this is a completely separate genome known as the microbiome that is very important in mediating outcomes to immunotherapy. Now, why is this an important deal? Now, as it turns out, we have many, many, many microbes within us. There are about 10 trillion human cells and about 100 trillion microbes. The number of genes that the microbes have, that we have inside us, outnumber us by a fold of not just 10, by about 100-fold. And for people who want to try and put that in context, 100 trillion is really many, many, many zeros. It's 4 times the amount of dollars in the national debt. And for those of you who may not know how much national debt we have, it is a lot. It's 25 trillion right now, and the number of bugs that we have actually outnumbers that by a factor of 4. And we increasingly realize that the gut microbiome plays a tremendous role in human health and disease. Anybody who has a member of the family with asthma, atopy, a form of inflammatory bowel disease such as ulcerative colitis or Crohn's, the microbiome plays a tremendous role in the severity of all of these features. The microbiome has been modulated, has been implicated in the development of behavioral disorders in patients with autism. And so there's this increasing appreciation of the role of the intestinal microbiome in mediating all these adverse outcomes, particularly cancer. So in the last couple of years, we've been really focused on trying to understand this, and the focus of the group is really helmed by what we now call the Microbiome Working Group at the Hillman Cancer Center, which incorporates both the co-leader of the melanoma program, Hassan Zaror, and myself. And so we've recently got some data that has linked 2 aspects of the microbiome in relation to 2 separate things in the context of cancer. And first is therefore the role of the microbiome in mediating response, but also side effects. So what we are recently about to show, and this is data that is about to come out, is really that people who have good bugs and people who have bad bugs, and you're able to tell the people who have good bugs and bad bugs separately, because patients who have good microbiomes completely segregate separately from patients who have bad microbiomes. So the good bugs highlighted here in blue appear to be overrepresented in patients who do well on immunotherapy, people who have good long-term response, or what is termed progression-free survival at 9 months or greater. On the other hand, there are people with clear adverse clusters of organisms who do not do quite so well. And we're able to tell these 2 people apart. Interestingly, in addition to mediating who does well or does not do well on anti-PD-1 immunotherapy, the gut microbiome composition also appears to distinguish between people who develop or don't develop side effects, particularly immune-related side effects, or irAEs. You see here that the composition of the gut microbiome readily segregates the people who develop immune-related adverse events, as shown in orange, from the people who don't. These organisms appear to at least fall into two separate classes, one class of which is characterized by the overabundance of an organism known as Streptococcus. And that organism is particularly associated with the use of proton pump inhibitors. And very interestingly, proton pump inhibitors, or PPIs, a drug that is actually readily available over the counter, has actually, in our data set, been shown to be associated with worse outcomes. And this indeed appears to be the reason why patients who have high Streptococcus have also, as shown here in the curve in red, appear to have worse outcomes. So we are now having increasing evidence that there are distinct metagenomic signatures that underlie both the people who develop good outcomes, that is response, but also develop side effects or immune-related adverse events. So as we developed these questions, we sought to turn our attention to the separate question of, can we alter the microbiome? Can we therapeutically intervene upon the microbiome to treat patients with severe immune therapy refractory melanoma? And can that result in anti-tumor responses? Now, we know that this is possible in mice, whether you use a single bacteria alone, and this is data from the University of Chicago from Dr. Luke's prior group, but it's also been shown in the context of fecal microbiome transplants from a group in MD Anderson, where if you take a whole fecal transplant from a responder donor, you can actually recapitulate that result in tumor-bearing mice who appear to not be responding to anti-checkpoint inhibitor therapy with the PD-1 antibody. So what we developed at the University of Pittsburgh in collaboration with our funding sources was to take a group of people who had completely refractory disease, people who had never responded to immune therapy, what is termed primary refractory or resistant melanoma, and give them a single administration of a fecal microbiome sample from donors who had excellent outcomes to checkpoint inhibitor therapy. Along with this, we gave them pembrolizumab, and keep in mind that this is a drug that they had already failed, so one would not have thought that the continuation of pembrolizumab would help anybody, but it was given to re-excite the body's immune system. And the idea here is to see whether or not the administration of the fecal sample altered the microbiome and re-engaged the immune therapy to work in these patients. Now, the donors that we utilized were patients who had excellent durable response to checkpoint inhibitor immunotherapy, were currently well, disease-free, cancer-free, and did not have any long-term side effects. They also could not have been exposed to adverse antibiotics in the recent time frame, and were also did not have any serious long-term illnesses such as obesity, diabetes, or any infectious diseases. Donors were serotyped. Donors were extensively screened for the presence of infections that could be transmitted through fecal samples. These included infections such as viral infections, as well as bacterial infections, fungi, and viruses, and as well as multi-drug resistant organisms such as VRE. And if they had these infections, they were not allowed to donate. After we identified our donors, the donors and the recipients were then matched to ensure that donors could not transmit anything to potential recipients. We had approximately 15 patients who were on the trial, 16 patients in total, 15 of whom were evaluable, and their characteristics are depicted here. Essentially, this is a group of patients who were relatively heavily pre-treated, as indicated by the number of median prior therapies, of whom it was an average of 2. And as Jason mentioned, the number of patients who had this adverse biomarker of lactate dehydrogenase, 93% of our patients had elevated levels of lactate dehydrogenase, indicating that this was a very adverse group of patients. What are the results? So you can see here that these are the patients who were treated on this trial, and these are their CAT scan results on treatment. Approximately 6 patients out of the 15 people that we treated and were evaluable had disease that either shrunk dramatically or disease that stopped growing significantly at an average now of time span exceeding 12 months. So to summarize, out of the 15 patients who went on treatment, 6 out of the 15 had durable responses lasting longer than almost 12 months. One patient had a rapid response, a complete response, but unfortunately passed away as a result of surgical complications related to actually spinal stenosis surgery, completely unrelated to melanoma. And the spectrum of responses included people who had rapid disease shrinkage, so people whose cancers just went poof, people whose cancers dramatically reduced slowly over time, and also people who had just long-term disease stabilization, people whose cancers apparently stopped growing and stopped changing over time. And along with that, we did see some people who did not respond at all to this therapy, but all of these people who responded either with a rapid reduction in disease or slow reduction in disease are termed responders for the purposes of our scientific analyses that I'm about to show you. The proportion of people who did do well is actually 6 out of 15, or about 40%, which is quite remarkable in a very heavily pretreated cohort. Very interestingly, the fecal sample readily engrafted in most patients. So you see here that in all our responders, what we see is that the responders had complete engraftment of the donor sample. And this is not surprising because if you don't engraft, it doesn't appear that the transplant appears to have worked. The degree of engraftment is shown here by the statistic on the left, indicating positive statistic indicating that the patients had engrafted. And the rate of engraftment was actually very interesting. The people who did well had a rapid and profound metagenomic change in the direction of their donors, as indicated here on with the responders on the right. And what we do know is that in people who were given transplants, the use of antibiotics was very, very, very adverse. Now, it's not, I'll go into this a little bit later, but the point is that the transplant, the fecal transplant, is a living, breathing drug. And when you give antibiotics, unfortunately, antibiotics that we have are not quite as selective as we would like. We have approximately 25 different classes of antibiotics since in the last 150 years, since Louis Pasteur discovered penicillin. And the antibiotics, unfortunately, can kill this transplant, as shown here in this patient. So this is one patient who received a transplant. This is a patient of Dr. Neja, and she received her first transplant here. And after that, there was a rapid reduction in the presence of the bad organisms highlighted in green and in brown. So over time, they went down quite quickly. Unfortunately, she developed a soft tissue infection and was treated with antibiotics. And you can see that after she was treated with antibiotics, the reduction in her cancer that she experienced, the reduction in the tumor sizes that she experienced were reversed, and the cancer actually started growing again. Fortunately, she was able to receive a second transplant from the same donor and was able to stop antibiotics, after which the cancer actually started reducing in size again, along with a reduction in the presence of those adverse organisms highlighted in orange and in green. And so what we're seeing here is in a single patient, we see the effects, the deleterious effects of transplant of the antibiotic upon the transplant, and the amelioration of said deleterious effect by a retransplantation from the same donor. The overall result of the transplant was a result in the engraftment of certain key bacteria. The major bacteria that were good were bacteria that belong to these two major classes of bacteria known as phylum. So the granddaddies of these bacteria were in the Firmicutes and Actinobacteria phylum, and in the following families: Lactanospiraceae, Ruminococcaceae, Erysipelotrichaceae, Bifidobacteriaceae, and Choreobacteriaceae. Whereas the organisms that were enriched in the people who did not respond, or were enriched in the pre-treatment samples of the people who went on to respond, were in the Bacteroides family. Now, what we were able to show in collaboration with our preclinical in the correlative analyses that came from the patient's tumors as well as in their blood, and this is all work done in Dr. Zaror's laboratory, is that the non-responders had much higher levels of a very, very adverse immunosuppressive cytokine known as CXCL8 or IL-8, and high levels of these adverse cells known as myeloid cells on treatment. So the non-responders had high levels of this, and the responders, after the treatment, their levels of these adverse cells went down. And separately, the responders had much greater levels of immune cells, CD8 T cells, which, as you've heard from many speakers before me, are key to mitigating the adverse effects of these myeloid cells, and are required and are a presence of activated immunity. Along with the CD8 T cells, responders also had increased amounts of effector memory cells, as well as mucosal associated invariant T cells, which are a specific class of CD8 T cells that are known to be dependent upon your native microbes and affect microbe-related immunity. So in summary, the intestinal microbiome is very, very, very important in cancer. Now, why is that the case? Firstly, anti-PD-1 immunotherapy, a class of agents that have been pushed forward by leaders in the field, such as Dr. Kirkwood and Dr. Zaror, is curative in 30 to 40% of melanoma. So it's curative for many of the people on this call have already received such treatment, and this treatment is migrating earlier and earlier and earlier into the therapeutic landscape of cancer patients. However, the majority of cancer patients, melanoma patients, will relapse either early on treatment, and that's up to 30 to 50% of treatment, or late on treatment. And so therefore, new modalities are needed. And what we've shown you is that in primary refractory melanoma, the microbiome modulation with this responder-derived fecal microbiota produces response in a heavily pretreated group of patients, not in just one, but in 2 independent studies. And this appears to be related to the fact that some people who are trying to respond to immune therapy want to, but are unable to because the presence of this adverse microbiome. And that what responder-derived fecal microbiota is doing is it's merely restoring the balance, putting the yin back in the yang to allow the patient to respond to checkpoint inhibitor immunotherapy. And this has now been shown in 2 separate independent studies, pioneering studies recently published in a major journal known as Science, one group in Israel and the other group actually in Pittsburgh, in which all of the investigators that are present on this call actually participated in. And so we're very, very, very proud of that fact. And so what we now know is that in checkpoint inhibitor treated patients, our deep profiling has uncovered the impact of this microbiome upon the response to checkpoint inhibitor immunotherapy, uncovering distinct microbiome-specific, gut bacteria-specific signatures of response, as well as the development of resistance and adverse events on immunotherapy. So it appears that the gut microbiome appears to mitigate both response and non-response, but also side effects. And we hope to try to interrogate how this mitigates and mediates with all the other signatures that are known to be important in affecting the response to checkpoint inhibitor immunotherapy. So what we are asking is the question is, can you use these signatures to both predict side effects, and potentially can microbiome interventions, besides treating just non-responder patients, can also potentially reverse side effects? And so what should you as a patient take home? The first thing to keep in mind is that if you have melanoma, and we now know that in the context of melanoma, both in stage 3 cases, stage 3 patients, stage 4 patients certainly, but also increasingly because of work led by Dr. Luke and by Dr. Kirkwood, patients with stage 2 melanoma are now receiving anti-PD-1 checkpoint inhibitor immunotherapy. So your diet, as Melissa and other people have said earlier, is very important. But the key element of the diet that is very important is fiber, not any kind of fiber. We don't want people chugging Metamucil, but particularly non-resistant starch is very, very important, because this appears to be a very important food for the good bacteria in the body. Probiotics may not be as helpful as you would like to think. I know GNC and my mother certainly wants to believe that probiotics are going to cure everything, but those expensive $200 probiotics that GNC sells and that my mother makes me buy may not be as helpful as you think. And there will be shortly some excellent data coming out from other groups showing that probiotics indeed may actually be potentially harmful on the effect of checkpoint inhibitor immunotherapy. Very importantly, the deleterious effects of antibiotics and proton pump inhibitors in the context of immunotherapy are real and reproducible. So please consider minimizing antibiotics and proton pump inhibitors. And finally, your side effects may actually be amenable to microbiome modulation. So if this is something that is a huge issue for you, please ask your cancer doctor or your advanced practice provider, and they'll connect you with us. After the failure of cancer therapy in the context of anti-PD-1, microbiome modulation may be effective. We have now trials in melanoma, but soon in other cancers as well. And so please, again, ask your cancer doctor, your advanced practice provider, and they'll hook you up with us. And finally, in the context of patients with checkpoint inhibitor immunotherapy who have been cured, that select 20 or 30% of you out there who are cured on immunotherapy, we want to study you. We want to study you, and we'd like to study your stool. So please call us, email us, call me. I think I'm one of the few doctors on the call whose cell phone number is available on Google. So please reach out to us. We're happy to take your call and we'd love to study you. These are our ongoing research efforts. We now have active interventional studies in melanoma, as well as in other cancers. We will soon have active interventional studies to treat side effects. And we're doing this active sampling. I have a research associate who's going and talking to many of you, asking you for your stool. So please consider donating. It's a very, very precious resource. You may not think of it as such, but we certainly do. And this is something that is going to power future research efforts both here and elsewhere. These are our funding sources, and this immense team, especially the clinical trials team that badgered, cajoled, and begged all of you to participate, and our research team at Dr. Zaror's lab, as well as a shared resource that helped power some of these analyses, and our collaborators at the NCI, without whom none of this will be possible. So thank you. I'm happy to take any questions.